In our country today, I think as many people know, we spend almost twice as much as do the people of any other country per capita on healthcare. That's about 18% of our GDP, and yet our healthcare outcomes in terms of life expectancy, infant mortality, and disease prevention are not particularly good in terms of international comparisons. And one of the reasons for that is that we have a major crisis regarding primary health care access, which results in lower quality health care for our people and greater expenditures. Lower quality health care, and yet we end up, because of the crisis in primary health care, spending substantially more than we should. Today, 57 million people in the United States, 1 in 5 Americans, cannot see a doctor when they need to. Lack of access to a primary care provider is a national problem, but those who are most impacted are people who are low income, minorities, seniors, and people who live in rural communities, whether it's Vermont or Wyoming. As we've seen time and time again with dental care, mental health, and other health care issues, the groups that need health care the most are the least likely to receive it. The good news is that just 11 months from now, we will be providing health insurance to 30 million more Americans through the Affordable Care Act. The bad news is that we don't know how we are going to be providing primary health care to those Americans who now will have health insurance. Let me just rattle off some statistics that I think should be of concern to the Congress and, in fact, to all Americans. Not widely known, but maybe Dr. Wilper will talk about this when he testifies, approximately 45,000 people every single year die in the United States of America because they do not have health insurance and they do not get to a doctor on time. 45,000 Americans. According to the Health Resources and Service Administration, we need 16,000 primary care practitioners to meet the need that exists today with a ratio of 1 provider to 2,000 patients. Over 52,000 primary care physicians will be needed by 2025. In 2011, about 17,000 doctors graduated from American medical schools, despite the fact that over half of patient visits are for primary care. Only 7% of the nation's medical school graduates now choose a primary care career. 7%. Nearly all of the growth in the number of doctors per capita over the last several decades has been due to a rise in the number of specialists. Between 1965 and 1992, the primary care physician to population ratio grew by only 14%, while the specialist to population ratio exploded by 120%. The average primary care physician in the United States is 47 years of age, and 1/4 are near retirement. In 2012, it took about 45 days for new patients to see a family doctor, up from 29 days in 2010. In other words, even if you can find a family provider, it often takes a lot longer than it should to see him or her. Only 29% of U.S. primary care practices provide access to care on evenings, weekends, or holidays, as compared to 95% of physicians in the United Kingdom. In other words, our culture is don't get sick on Saturday, Sunday, or night. 9 to 5 works pretty good. Half of emergency room patients would have gone to a primary care provider if they had been able to get an appointment at the time one was needed. In other words, we are wasting billions of dollars because people end up in the emergency room for non-emergent care because they can't find a primary health care physician. In my view, and I think the view of all of the experts who have studied the issue, primary care is intended to be, and should be, the foundation of the U.S. healthcare system. In 2008, Americans made almost 1 billion office visits to the doctor. 50% of those visits were to primary care doctors, half. According to virtually every study done on this issue, access to primary health care results in better health outcomes, reduced health disparities, and lower spending by not only reducing emergency room, but when you get people to the doctor when they should, they don't get sicker than they otherwise would be and end up in the hospital at great cost. The problem we are discussing is clearly a national problem existing in 50 states in the country, but it is even worse for particular geographic regions. The ratio of primary care doctors in urban areas is 100 per 100,000 people. Double the ratio in rural communities, where it is 46 per 100,000. So urban communities clearly have problems. Rural communities have even greater problems. 65% of primary health care professional shortage areas are in rural counties. My own state, we do much better than the rest of the country in terms of primary health care providers per 100,000. And yet I can tell you that in the state of Vermont, people often have a difficulty getting to the primary care provider they need. Although 20% of Americans live in rural areas, only 9% of physicians practice there. One of the significant differences between the U.S. healthcare system and the healthcare systems of other highly developed countries, which could significantly explain why we spend so much more than other countries around the world, is the ratio of primary care physicians to specialists. In the United States, roughly speaking, 70% of our practitioners are specialists, 30% are primary health care providers. Around the rest of the world, that number is exactly the opposite. About 70% of their practitioners are primary health care providers, 30% are specialists. What can Congress do to address this very serious issue? Let me just rattle off a few points and give the mic over to Senator Enzi. First and foremost, clearly, we must address the issue of primary care reimbursement rates. Specialists earn as much for their lifetime of practice, as much as $2.8 million more than primary care providers. So if you're going into medicine, if you're a specialist, you can earn throughout your lifetime almost $3 million more than a primary care practitioner. Radiologists and gastroenterologists, for example, have incomes more than twice that of family physicians. The system for setting physician reimbursement in this country is largely determined by the 31 physicians who sit on the American Medical Association Committee, called the Relative Value Scale Update Committee, generally called RUC. The RUC, whose payment recommendations are accepted by the Centers for Medicare and Medicaid Services over 90% of the time and are adopted by many private insurers, is dominated by specialists. So specialists sitting on the committee determine reimbursement rates. We have to look at that issue. Medicare has promoted the growth of residencies in specialty fields rather than primary health care by providing significant sums, $10 billion each year, to teaching hospitals without requiring any emphasis on training primary care doctors. Serious issue. Thirdly, unlike other nations which provide significant financial support for medical school education, we by and large do not do this in this country. And the result is the median debt for medical students upon graduation is more than $160,000, and almost a third of medical school graduates leave school more than $200,000 in debt. Now, if you're leaving school $200,000 in debt, what are you going to do? You're going to try to figure out how I make as much money as possible to deal with that debt. And you're going to gravitate toward those fields which pay you higher incomes. So, if we're going to attract young people into primary health care, we must make that profession more financially attractive. In other words, we must address the issue of how reimbursement rates are set for Medicare, which impacts reimbursement rates for all physicians. Second of all, in recent years, and I have worked on this issue, other members have worked on this issue, We have greatly expanded community health centers around the country. And community health centers provide very good quality, cost-effective health care. We need to do more than that. We've made progress. We need to make more progress. We need, in recent years, we have significantly increased funding for the National Health Service Corps, which says to somebody that if you're graduating medical school $200,000 in debt, we are going to help you address that debt. We'll help you pay it off if you practice in underserved areas. It is working. It has worked. We've made progress. We need to make more progress in that. Teaching health centers. Studies have shown that residents trained in community health centers or rural communities are more likely than those trained in other settings to make a career practicing in underserved or rural areas. The THC program was the only new investment in graduate medical education in the Affordable Care Act, and the 5-year funding was only $230 million. We've got to expand that concept. We've also got to take a hard look at the role of allied health providers, nurse practitioners, and others. How do we better utilize those people in the provision of health care?